Right, hello everybody. Congratulations for turning up this morning. So the Banff meeting's a bit like a biopsy actually. It's a cross-section of a living thing that's moving on, and there's evidence of things that are completed, there are things that are going on that you need to pay attention to, and then there are some hurdles ahead that you also need to think about and design to meet those challenges. So this snapshot this time I think was a really good meeting for the Liver Group. As you can see, there's a breakdown of the sort of topics that we were dealing with, and I'm going to run through the individual lectures to give you a flavour of what was actually said. But we had a small group, but I think more than 90% of those present had their say at least a couple of times during the meeting and through the meeting. So there was a lot of opportunity for discussion. I think we tend to have more discussion than the kidney groups, which is partly a function of the size of the group. But the talks are punctuated by long discussion. So Desley Neal led the working group looking at evaluation of steatosis in donor liver frozen section biopsies, and that was begun at the last Banff session, and this is a work in progress which she presented. They have provided a definition for macrovesicular fat, the sort of fat that seems to be more important to assess, and there are morphometric methods to validate what the pathologists are doing with an online set that is a real set of biopsies that were used to make diagnoses in allografts for which we're collecting some outcome data. So a group of pathologists from around the world scored the second set because there was a first set presented at the last meeting. Then Desley designed, with a lot of work actually, a training set where you could look at a case, and then after you finished this case you would see the morphometry and the calculation of the results to get yourself in sync with what the process involved. And then the pathologists, some of whom were repeat and some of whom were new scorers. And to skip straight to where we are just now, there's a clear convergence after definition and training, which is what you would hope for, but we're bumping up now against the actual quality of some of these sections. And as I said, these are real biopsies, and on those cases, they are impacting on decision making. So Desley will be taking that forward, doing a bit more work and keeping it going. As I said, this is a snapshot of something that isn't finished, but I think the convergence is really quite impressive. And it's good, it's what you expect and hope for, but it's good to see it. Claudia Mescoli gave a fantastic presentation looking at what do we do when we report rejection in liver biopsies, and is it time to think about how we do this and adapt to the new challenges of the long-term liver allograft. She gave a very exhaustive and complete review of the terminology, definition, criteria and the scoring system, and somewhat akin to what the kidney people are going through at the moment, looking at should we be thinking of activity and chronicity as indices, should we be trying to bring in the various patterns of diagnosis of rejection that characterize early versus smouldering versus late allograft rejection. She had done some work on a slide set of her own to try and validate some of these newer markers for herself and to present to us and for practice, and presenting a couple of tentative schemes that the group here and those who haven't been able to make it here will be able to look at right after this meeting, in fact, with a view to trying to get an online consensus for the way forward in this. And I think everybody's very supportive, and the general idea is to evolve rather than to revolve, and to add on some of these new elements that need to be added on, but not to lose the elements that are working well, and then to test these systems with a reality check on a set of cases that's already up online and managed with Claudia and Drew Lesniak's help, so that people will be able to get straight to looking at these systems together. So that was I think most people felt that was a really important thing that needs to get going now to maintain the relevance of the system and keep it pushing ahead. Maria Field, I just jumped something now. Maria Field gave a presentation on it's a pathological presentation reviewing the entities related to rejection that you encounter after transplant, which sort of fitted with the theme of the late biopsy and was a very in-depth analysis of the pathological changes and the challenges therein. And this synced with the other working group, which is looking at nodular transformation of the liver. As the liver allograft goes for extreme lengths of time, and I'm talking about 2-3 decades now, one of the commoner changes reported, and which we're beginning to see and is likely to become important in these long-term survivors, is the nodular regenerative hyperplasia. But there's not a lot of definition, there's not a lot of recognition of the pathogenesis of this process, the contribution of potential alloimmunity for pruning the vascular tree and leaving the rest of the liver to become nodular as a compensatory hypertrophy. So Fundi Yilmaz and Milen Sivak have been doing work together and individually on different cohorts, and we had a presentation on a set of native and allograft livers discovery presentation where they developed a RET score based on the reticulin stain that you really need to be able to pick up these changes early on, and there's no real definition and consensus about the early changes. And their study, their discovery study, really did show that you can identify these early changes and that they do seem to correlate with clinically significant parameters, particularly portal hypertension, and therefore they're moving forward to a validation cohort. So the next presentation really from that group was Milen in a different session, but looking at NRH, nodular regenerative hyperplasia, in very long-term surviving liver allografts. Her centre has protocol biopsies for allografts really going out to 20 years and more, which is almost a unique data set. And so she's able to really look at these long-term allografts and the pathology that's going on in them, and what do they represent in terms of challenges that other centres with very long-term survivors are going to be facing soon, because that's one of those challenges coming up over the horizon as we extend the success of liver transplantation. Okay, so we had a set of sessions about tissue monitoring and a set of sessions about non-invasive monitoring. And Jeff McCaughton sort of led the beginning of the session on the clinical aspects, reviewing the role of the biopsy from a frontline practicing patient-facing clinician point of view. I pointed out that really the evolution of progress in liver allografts is slightly stalled. The early days have been very successfully negotiated, but there hasn't been a lot of progress in recent years, particularly with dealing with the slope of that long-term decline of liver allograft survival. So this remains a problem. He went through the various aspects of analysing the tissue and the challenges that we face. And one of the challenges really is getting long-term tissue protocol biopsies of these well-functioning allografts, because there is a significant amount of pathology in them. We've known that from biopsies in the first decade, and we're beginning to discover what sort of pathology is present in the long-term biopsies in the second decade. We don't have a lot of data on that, and we don't have much enthusiasm in many centres for doing these long-term biopsies in patients who are perceived to be clinically well-functioning. And this was a recurrent theme, and I'll come back to that in a minute. Michael came along and gave us an absolutely state-of-the-art presentation of where we are with expression technologies, which are obviously becoming an integral part of analysis of tissue. And if you're getting tissue, you want to make the most of all the dimensions of that tissue. And he covered for us the history of the topic, the difficulties and the great difference between coming in the morning and saying, I think I've got a great test, and moving that test to be one that other people use in their laboratory with confidence that it's going to work and be useful. And that's a big hurdle, and he covered those aspects and led us up to the latest developments in technology and the ways in which you can break down the tissue with your spatial transcriptomics and look at functional aspects rather than simply collecting a lot of expression data and trying to reconstruct cells, actually looking at what those cells are doing, what they were doing, and therefore what they might be doing in the future, and pulling that back to the tissue interpretation of routine stains that we are aware of. Yeah, I gave a presentation, I'm afraid, and dealt with three aspects. First was the portal tract. I went into some detail about the microanatomy of the portal tract and how that relates to the function of the liver as an immune organ, and then followed that on to portal fibrosis, what we now know about the key cells developing fibrosis in the liver, which is the small subset of mesenchymal stem cells with fibroblastic function in the portal tracts that really are able to proliferate and expand into myofibroblasts and dominate the generation of fibrosis in the liver. And I drew people's attention to the cell circuits, two-cell circuits, as a way of getting an extra dimension of understanding what's going on, because sometimes you have no inflammation or scarring, but that is a process that's already locked into the tissue that you're not capturing simply because of the kinetics of responses to some types of tissue injury, and that these two-cell circuits are a good way of looking at the, for example, hot fibrosis, cold fibrosis, and stable states, and how you nudge a cell from returning back down that whirlpool to a stable state into another place where it now has a new stable state that's pathological, and how you might change that. I looked at the microanatomy then of the inflow of the liver, because the long-term liver allografts, there are pinch points that are subject to autoimmunity because of their microanatomy, and that then influences what you are going to see in the long-term liver allograft. And then I switched to the lobule and looked at innate immunity, because small changes in innate immunity might be nudging the liver off course over, when we're talking about 20 years, these stable states matter, constitutive innate immunity, and looked at how the lobular, the immunity of the liver is polarized towards surfaces, i.e. the inflow portal surface, the capsular surface, how that's managed, what the implications are to have a zonal gradient of immunity, and how innate immunity such as dysbiosis might be affecting that, how rather speculatively how other things like repopulation of the graft, which happens obviously after transplant, might be affected by things like clonal sweeps in myeloid stem cells that we will get as we get older. Then Elmar Jacob gave a fantastic presentation really advocating the use of the tissue sample to know what's going on in long-term allograft. And he emphasized the safety of this procedure first, and that the benefits way outweigh any perception of risk, and that is a hurdle, that's a mental hurdle that people need to get over. And I think he was pushing against an open door with this audience here, with this statement, but the wider audience really does need to be convinced. And he gave us a roadmap of the state of the art in the subject, the field, and what his own group's results have shown, and how useful tissue samples are, and how necessary at the moment they are to these very long-term survivors in whom we just don't have the data that we would like. We imagine we do because we have some long-term survivors, but we actually don't have the data we need to mold those subtle changes in the balance between immune benefit and immune morbidity from the immunosuppression. Annette gave a great presentation about the evolution of the understanding of DSA in liver transplant, and how we really still have a lot to know. The quality, the quantity, how to monitor, what's best to monitor, whether you should be under-monitoring, over-monitoring at the moment, how to use these tests as a companion to the other inputs that the clinician has. And that was a really good state-of-the-art summary. Josh we're now into the non-invasive tests. Josh gave us a good summary of work he's been leading on cell-free DNA as a non-invasive test, which is at the moment very expensive, we heard, but with time, like all these things, is going to improve. And it is really one of those ways of being pragmatic about managing immunosuppression, and the balance that kept coming up between the morbidity that the patient suffers from immunosuppression, which is an accumulating background thing, and the benefit of saying we need to tweak the immunosuppression to improve the immunity against this graft. And he was pretty positive about cell-free DNA and where it is at the moment as a test that has strong promise. I think that's probably fair enough to say what he was saying. And Thomas gave a good presentation about elastography, which is a relatively simple, available test in many transplant centers, and it measures texture changes in the allograft that are not specific, but are very useful to give you negative predictive values, to impress on patients that there might be a need for them to come to a tissue sample. Give some lovely clinical examples there, and cover the pros and cons of this investigation and concluded that it is a good thing if, like most things, there is a Goldilocks zone for using these tests for benefit, because you can't keep biopsying patients and giving tissue samples. Sandy, as always, exploded onto the scene and really gave us a broader, high-level view of we have problems. We have alloimmunity that is incremental in these long-term survivors and is producing long-term fibrosis and scarring and nodularity that is very significant morphologically, but in the day-to-day activity of this process is very tiny. And so you can argue that we therefore need to tweak alloimmunity. However, the flips of the side is that these are very long-term surviving patients, and the morbidity and mortality of immunosuppression is a dominant feature of their landscape in the future as they live longer. And therefore, what should we be doing and how should we be doing it? And she really began to integrate the preceding presentations in terms of what are the wider considerations. You can really get your head buried into your tissue sample and what it's showing, and forget, particularly as a pathologist, of course, forget the wider issues confronting the clinician and the patient. And of course, there are many patients in whom immunosuppression is too strong, and we need to be better able to identify them even late on and to tweak their immunosuppression in such a way that you don't overdo it and end up having to give them bolus immunosuppression that undoes everything you're trying to do and gives a legacy hit for the future in these people. So it's a tightrope. And she gave us the problems, the challenges, and the group had a big discussion about this, which Jackie really brought to a head with summarizing what had come before, trying to identify a pragmatic way forward. And I think the frontline patient-facing clinicians in the group had a great discussion and were very enthusiastic about the use of tissue biopsies, about the use of when you have a group of patients who have settled down to what standard of care, say tacrolimus levels, how to approach in a pragmatic and useful way, taking some of those patients a little bit lower. Not talking about removing immunosuppression, but going together to try and find an ongoing way to lower the immunosuppression in a pragmatic way. And I think that's where we ended with a lot of enthusiasm for that among the patient-facing clinicians and the pathologists, with a lot of enthusiasm for reinventing our staging and grading systems to face new challenges and to give a holistic system that, like most of the Banff classifications, everybody with their own experience wherever they are feels that that system is offering something for them, and it's a system they're comfortable to use with a low cognitive load that allows them to produce informative reports that can be translated across the world and make the best use of other new data that's coming in. So I think, if I haven't overstayed my welcome, the liver sessions were pretty productive, and just like a tissue sample, there's a lot that's happened before and that we can now move forward from, and there is a lot that's bubbling on at the moment, and a few challenges that I think we can appreciate, and we've identified what we believe to be the major ones, and I think the really long-term allograft survivor is one of those. So thanks very much.